Thanks very much, everybody, for joining us this evening. We're going to talk to you about Pharmacy First and how you can maximise success with this service. I'm joined by a number of colleagues this evening, and I think it's probably easy if we just introduce ourselves when we start our section for each of the presenters. My name is Alison Scowcroft, and I'm Community Pharmacy Clinical Lead for NHS Greater Manchester. So in terms of a little bit of housekeeping, please, we will share the slides with everybody who's attended after the event. So if you do want a copy of the slides, can you put your email address in the chat box, and then we know who to send the slides out to. We'll make them available on the LPC website as well. Please do mute yourself to avoid interference. We've got a few different people talking tonight, so it'll be much easier if you can mute yourselves, and then we don't get any interference with the session. We have got a new function in Microsoft Teams, which is the Q&A. So you should see in the toolbar at the top of your screen somewhere a Q&A symbol on the left-hand side. So if you do have any questions for us, pop them in the Q&A. We've got a couple of people who will be keeping their eye on that Q&A throughout the course of the webinar, and you'll either get a response during the webinar, or we'll pull it out in the Q&A session at the end. If we're seeing some common themes of questions, we'll discuss those together in the Q&A session at the end, and there'll be plenty of time for questions for anybody who wants to come off mute and talk to us once the presentation's completed. So if everybody can just make sure they're on mute, that would be great. Thank you. In terms of the agenda, we're going to give you a little bit of an overview, our Pharmacy First, hopefully preaching to the converted with this one, because I'm sure all of you have been providing this service for the last month or so. We've got a little bit of coverage around some teething issues, some teething challenges that we've had. We've got a little bit of data to share with you to let you know where we're up to so far. And then we're joined by a pharmacist within Greater Manchester who's going to share his story with regards to Pharmacy First so far. We've got a little bit around professional standards, and then we'll cover some supporting resources that we've got available for you, and then we'll go to what's on your mind. So what questions and comments do you have for us at the end of the session? So just to kick you off, I'm going to give you a little bit of an overview of Pharmacy First service. So as I'm sure you're aware, it's an advanced service, so it's optional for pharmacies to register to provide the service, and it includes the 7 new clinical pathways. Pharmacy First replaces the Community Pharmacist Consultation Service, the CPCS, and this is one of the most important high-profile services that we've ever had in community pharmacy. There's been a huge amount of media and press attention around Pharmacy First service, and there's a national media campaign that's due to land in the next week or so that NHS England have sponsored. So it's really high profile. Everybody is watching us. They're watching community pharmacy to see how we deliver this service. So there's 3 elements to Pharmacy First. The first element is a referral for a minor illness consultation with a pharmacist. So that was what you will have known as a CPCS previously, where you received minor illness referrals from general practice, from UEC if you're in certain areas, and from NHS 111 and 111 online. The second aspect, or second element of Pharmacy First, is the urgent supply of repeat medicines. Again, that was previously part of CPCS, and that was where your referrals for urgent meds came from 111, 111 online or UEC, but not from general practice. The third element is the new element. This is the clinical pathway consultations. So CPCS plus clinical pathways is Pharmacy First. So if you've opted in to provide the service, you have to provide all 3 elements of the service. It's not optional. Registration to provide the service means you provide all 3 aspects: the minor illness consultations, the urgent med supply, and the clinical pathways. Patients can present into the pharmacy for clinical pathways consultations only. So all the other aspects are still a referral only route. Your clinical pathways consultations can be provided remotely. And if you do remote consultations, they must be via high quality video link. And the only clinical pathway consultation that you can't do remotely is the acute otitis media pathway. And that's because part of the PGD requires you to use an otoscope to investigate the ear. Distance selling pharmacies can provide the clinical pathways consultations, but they must do them remotely. And that's because of the link to self-care and essential services. And DSPs cannot provide the acute otitis media pathway at all because of the requirement for an otoscope. There's a few little complications around how the service needs to be provided. But just to flag and reiterate, there's no changes to the former CPCS elements of the service. So where you previously received a referral through CPCS, either from general practice, UEC or 111, you will still receive those referrals in the same way for Pharmacy First. And telephone consultations are still possible where clinically appropriate, just not for your clinical pathways consultations. I'm sure you've probably seen this high-level overview before, but it's just a really nice summary of how it all works. So on the left-hand side with the greeny turquoisey box in the middle with the referrals, all of that is pretty much the same as what we had for CPCS. The only difference is that you've got your clinical pathways referral added in here. And if the patient meets the gateway criteria, then they will have a clinical pathway consultation. If they don't meet the gateway criteria, then it tips into a minor illness consultation, as you would have done for CPCS. The main difference with Pharmacy First is that we can now have patient walk-ins, which I know is something that we've all been asking for a long time. The patient walk-in is only for the clinical pathways element. So if you've got a patient who has minor illness symptoms that don't meet one of the 7 clinical pathways, then they have to be referred. You can't do a Pharmacy First consultation for them. But if a patient presents in the pharmacy with symptoms that are indicative of one of the 7 clinical pathways conditions, then you can introduce them into the clinical pathway consultation if they meet the gateway criteria. If that patient presenting in the pharmacy doesn't meet the gateway criteria, then you're going to default to your self-care essential service and provide advice to that patient over the counter. So please do familiarise yourselves with the service specification. There's a more detailed diagram in Annex A there. In terms of the clinical pathways consultations, again, I'm sure that all of you are familiar with these 7 conditions. And also the age ranges. So these are specific to the PGDs in terms of supplies that you're able to make. So uncomplicated UTI in women aged 16 to 64, shingles in adults aged 18 years and above, impetigo and infected insect bites aged 1 and above, sinusitis is aged 12 and above, and sore throat aged 5 and above, and acute otitis media only in children, so age 1 to 17 years. If you get referrals from general practice or UEC or 111 for patients who sit outside of those age ranges, you can still see them as a Pharmacy First minor illness consultation, even if they don't fit into the clinical pathways consultation. In terms of funding, you will receive £15 per completed consultation. And you'll get a monthly fixed payment of £1,000 where you meet the minimum number of clinical pathways consultations. And you can see there's a table on the side there that shows how that minimum number of clinical pathways consultations builds. So in February, you just had to do 1. For March and April, you need to do 5. And then from May through to July, it goes up to 10, 20 in August, September, and then building up to 30 in preparation for the winter period from October onwards. From April, there is an initial cap of 3,000 consultations per pharmacy per month. And from October 24, new caps will be introduced based on the actual provision of clinical pathways consultations. And the aim is to try and deliver 3 million consultations per quarter. So NHS England are really looking to community pharmacy to step up and deliver activity in this service. In terms of the consultation outcomes, so once you've completed a consultation with the patient in the consultation room, for CPCS, there were 6 outcomes. So they are exactly the same as they were in the green and the amber and the red boxes, dependent upon the urgency of the patient's need. With Pharmacy First, we've obviously added in the blue one, which is the clinical pathway PGD supply. So all of your options remain the same. So you can just give advice to the patient. That can include written information or a recommendation to use products that the patient might have at home, like ibuprofen or paracetamol. You can give advice and encourage the patient to purchase a medicine over the counter. You can give advice and refer them into the local minor ailment scheme where it's commissioned, where the presenting symptoms and the patient are included in that locally commissioned eligibility criteria. You could give advice to the patient and some non-urgent signposting to another service, for example, an optometrist, or to the GP for a routine appointment. So something that's not particularly urgent, but they do need to be seen by the GP. You've now got clinical pathways, so you've got the option to make a supply of a prescription-only medicine under a PGD. And actually, if the patient does require some more urgent attention, then you can have an urgent escalation to the GP, where you will support the patient to access an urgent same-day appointment with the practice. Or in a minority of cases, the patient may need more urgent escalation to A&E or ringing an ambulance. So I'm going to hand over to Lovejoy, who's going to talk you through some of the teething challenges and the story so far with Pharmacy First. Thanks, Lovejoy.
Thank you, Alison, and good evening, everybody. So as Alison said, I'm just going to cover the story so far and the key challenges and what actions we've taken to help resolve them. Next slide, thank you. So what challenges have we had? The first challenge that we have had is the IT issues with pharma outcomes. So the actions that we've taken is the LPC and the team here have raised this with Pinnacle, and we have also, as LPC, shared this information nationally as well. GM have met with pharma outcomes directly and been resolving issues with them, and liaison is ongoing. There's also been issues raised with DOS, especially with DSPs, and there is ongoing work to resolve this issue nationally. The other issues that we've picked up are general practices understanding of the service. So to counteract this in GM, we've had 4 GP-PCN drop-in sessions, and they've been very, very well attended, and there's been good engagement on that front. And we've also continued to engage in other forums, for example, the practice managers forums, clinical lead meetings, and also ICB leadership forums to ensure there's an understanding in the system of what the service is and what should be sent to you. General practice have also raised concerns on their side, and as a team, we are addressing individual concerns raised by practices directly with them. Next slide. And in terms of community pharmacy preparation, it was a very short timeline. There's a lot of hard work that's come from contractors to prepare for this service. We've delivered multiple face-to-face clinical training sessions, so that's over 700 places, which has been, really well attended. We've also held a number of community pharmacy drop-in sessions, and we've also developed guidance to help you, such as operational top tips, training summaries, professional standards document, and there's a spotlight on services almost weekly inside the CPGM newsletter. And in terms of the integrated working between community pharmacy and general practice, there are already a set of GP interface principles, but we are going to be engaging with GM to refresh these to help the system understand how best to communicate and build that relationship to deliver this service effectively. Thank you. And at this point, I'm going to hand over to Ali to talk about the Pharmacy First data. Thanks, Ali.
Thank you very much, Lovejoy. My name is Ali Khalaf. I'm the project manager of the Nationally Commissioned Pharmacy Services program team, and I'll be talking about the data of Pharmacy First tonight. But before I start talking about the data tonight, I need to mention that all the data that you'll be seeing in the next few slides are for the Pharmacy First referrals sent by GP practices and urgent and emergency care centres only. So it does not include NHS 111 referrals, urgent supply of medicines, or walk-ins consultations. And the period that I'll be talking about is going to be for the first 3 weeks of the service only. So that's from the 31st of January to the 22nd of February. So it's the first 3 weeks only. Next slide, please. As an overall, we have seen a very high level of engagement from both GP practices and community pharmacies with Pharmacy First compared to previously with the GP-CPCS. This graph on the right-hand side shows the number of GP-CPCS referrals made per month in the last 4 months of the service compared to the total number of Pharmacy First referrals that was sent for the first 3 weeks only. So you can see there's almost 2 to 3 times increase in the number of referrals. We also saw a higher proportion, around a third more of practices using the Pharmacy First for their patients in the first 3 weeks compared to GP-CPCS for the month of January. So around 300 surgeries have sent Pharmacy First in the first 3 weeks of the service compared to only 200 that used GP-CPCS for the month of January. We also have high level of sign-ups for the service from community pharmacy in Greater Manchester. Around 98% of all pharmacies in Greater Manchester have signed up to deliver pharmacy first, compared to 92 previously for the CPCS. Next slide, please. As Alison mentioned earlier, Pharmacy First has three elements: the minor illness consultations, the urgent supply of repeat medication, and the new clinical pathways for the 7 common conditions. So in the first 3 weeks of the service, only 1/5 of all referrals that were sent by GP practices and UECs resulted in a clinical pathway consultations. That's around 1,630. I just need to mention here the 1,630 clinical pathway consultations did not necessarily result in medication being provided under PGD. It could have been one of the other outcomes, but the total clinical pathways were around 1,600. So it's around 1/5 only of all the referrals that were made. So around 81% of all the Pharmacy First referrals were still minor illness consultations, which previously was called GP CPCS, or if it's from UEC CPCS. So the data so far is showing that Pharmacy First is driving the activity of minor illness referrals more than GP CPCS did previously. And this slide here is a breakdown of the 1,630 clinical pathways that was delivered by community pharmacies in the first 3 weeks as a result of more than 8,000 total referrals of Pharmacy First. So the graph on the right-hand side shows the number of clinical pathways for Pharmacy First referrals from GPs and UACs, and on the left-hand side it shows the percentage of the total clinical pathways. As you can see, acute sore throat seems to be the most common condition, and shingles is the least. And just to mention, we only have one UEC in Manchester, in Greater Manchester, Rochdale UTC, that is live and active with the service. That's why the number of referrals are very low compared to referrals from GPs. Next slide, please. The final part, I'll be talking about the rejection referrals. So these are these are situations where the referrals are being returned or rejected by the pharmacy without carrying out the consultation. And the first slide is talks about the inappropriate rejections and some explanation to why these rejections were inappropriate. I'm not going to go through all of them, but as an example, I will mention the second one. For example, difficulty swallowing is a red flag, and this patient needs to be seen by a clinician, a pharmacist. Obviously, red flags should be escalated appropriately, and escalation and signposting are actually outcomes of the consultation, a reason to reject it. So in this situation, the pharmacist should have escalated or signposted, depending on the situation, the patient, and this consultation should have been completed and claimed for. Next slide, please. In this slide, I've listed the missed opportunities. These are situations where the pharmacy have rejected the referral, therefore no payment is due, where a consultation could have been completed and a service fee could have been claimed. As an example, the second one, not Pharmacy First referral, completed under the minor ailment scheme. Instead of rejecting the referral, minor ailment scheme could have been the outcome of the consultation, generating an income for the pharmacy. So this consultation could have been completed, and both the minor ailment and the Pharmacy First referral consultation could have been claimed, because the minor ailment scheme is actually an outcome of the service. Next slide, please. My last slide here is just example where situation that rejecting the referral is the most appropriate course of action to take. So obviously there will be situations where, you know, the pharmacist will have to reject the referrals. For example, if the patient is uncontactable despite several attempts, or if the wrong type of referral has been sent. wrong patient, for example, or duplication. This situation, obviously, the pharmacist should reject the referral and take the appropriate action. If it's for the wrong patient, for example, the practice should be contacted to refer the right patient to the right pharmacy. Next slide, please. And I'll hand you over now to Amal to speak about his pharmacist view. Thank you very much.
Hi, everyone. Thanks for joining. My name's Amal and I'm a community pharmacist, and I've just been asked to share my experience and how I feel about the service so far. So, like all of us, we were presented with this service a while back, and for me, I went through the service and looked at the specs, like Alison said, the 6. I'm going to focus mainly on the clinical pathways. And for me, it was an absolute game changer. It's an opportunity for us to actually support our patients and go that little bit further than we had previously. And the context I'm putting it in is how many times have people come into our pharmacies with an insect bite or a sore throat, and we know what they need, or a UTI, and we really want to treat them, and we know what they need, for example, flucloxacillin, a UTI, some nitrofurantoin, and we've had to turn them away, and they say, I can't get into the doctor for a week. So for me, this service really puts us in a position to, one, be ambassadors of the profession, to say that we are clinicians and we're able to treat patients. So how did I prepare for this? And that's a big question. Big thing, big change for us. For me, I started with engaging with the team. So we've all got our dispensers, our ACTs, and making sure they fully understood what the service was and what we're able to do and what we're able to offer our patients, not just from referrals, but from patients just walking in with queries, maybe say, I've got a water infection, can I buy some cystitis stuff? So that's immediate for me, the staff, to say, can you speak to Amal, or maybe ask some further questions to get more involvement. So is looking at both avenues, that we do get referrals in, but for me as a team, it's capturing the people that actually walk into our chemist. So I spent a lot of time engaging the team, making sure they understood the scope of the practice and knew what the age range is, like Alison eloquently described, for otitis media or UTIs. And for us, we've been pharmacists for a while. There'll be a range of experience out there, and it's just building on the knowledge we've already got. It's just taking that little bit step forward and using our skills to ascertain what's the best course of action for these patients, and seeing the consultations through to the end. So is it the journey from the customer, from attending, not feeling well or not too sure what's wrong with them, is to have effective consultations with these guys and take them to the end. So how did I make this service a success? How do we make it a success? And I feel like I've done quite well in the beginning with it. And for me, was the big thing was, next slide, please, Alison. The big thing for me was, how do we engage our surgeries? The biggest thing is, do our surgeries understand? And as pharmacists, we sort of keep ourselves a bit separate from the doctors in some cases, but this is an opportunity for us to get into the surgeries, speak to the practice managers. But for me, is more importantly, I spoke to all the girls that answered the phone, so the triage in the morning. So I explained to them the service. I spent about 10 minutes talking them through. And a top tip for me was, I printed out the 6 pathways, who can be treated, what can be treated, and how it can be treated. I laminated them and said, look, put this by all your phones, guys. And if any of these patients turn up with these sort of symptoms now, as well as a minor ailments, we can actually help you. We can take that appointment away from the doctors, and we can see the patient in our pharmacy today. And we agreed a sort of pathway between me and them. And it'll be different in different localities, depending on your relationships, how you get on with your doctors, or how you get on with your practice manager and the receptionist staff, because they are key. The person at that desk is the person that's the most influential in triggering a referral for us. And once I'd done that, I saw 1 or 2 coming through, and it was about going in every day, every other day, saying, look, you must have had, how many phone calls did you have this morning, guys? And he said, we had a few. I said, I haven't seen a single referral this morning. You're telling me that nobody had a minor ailment or something I could have had a look out for you? So as they got their head around it and understood that we could take 10 appointments off them that day that free up the GP capacity to deal with other things. They're really engaged behind the service. So it's important to have numbers of, for example, I have numbers for all the receptionists and all the staff in the back that will text me, Amol, can we treat this? Can you treat that? And it's important to have that dialogue and keep it live on a daily basis. If if you're next door to a surgery, fantastic. Like myself, I can walk in every day. How's it going, guys? What sort of referrals can we send today? And it's really important that we really passionately get behind working together with the surgery. And I think for me, that was a leveler to make this service a real success for us. And we have to, like Alison quite clearly said, we have to make it a success, because we've been given this golden ticket to say we are now not just people who stick to labels on boxes and say take 1-3 times a day, come and I'll see you in 6 weeks, or here's some amlodipine, I'll give you a new medicine service. We can actually treat you, we can examine you, we can understand your condition and actually go that little bit further and hopefully help to treat you. The other part of it is, the next slide, is community engagement. Obviously, Alison mentioned that there's going to be some media campaign, but we see our customers on a daily basis, and we see mothers with young children, we see women. We should be talking to them all the day. Say, if you get a prescription, for example, for doxycycline, what's the doxycycline for, Mrs. Smith? And they'll say, oh, I've got sinusitis. I'm waiting for a week for an appointment. I said, did you know next time if something like that happens in your friends or family, I can treat you. I'm here to do it. We're able to do this now. So self-promotion is key. So surgery relationships, massive. Number 2 is get out there, get your teams involved to speak about the service. It should be a continual chatter on the counter that, you know what, if you get bit by an insect bite, a horse fly or whatever, we can help you now. It's not a matter of I have to refer you to the doctor. We're in a position that if it's appropriate, we can help to treat that condition. The big part of this, the next slide please, Alison, is effective consultations. Now, I think a lot of us would have started off, depending on what experience or if we're IPs or not IPs, is the consultation's key. And creating time in our busy pharmacies is the biggest challenge we have today. Is we have a contraceptive service, we have APBMs, we have blood pressures, we have NMS, we have 1,000 plates to spin at the same time. And the trick we have to sort of get our head around is, how do we create appropriate time to, one, give safe and effective consultations, because we don't want to rush them, make decisions that are, because they're time critical, we've got someone waiting for a prescription. Is we need to be looking at our skill mix within the branches. Have we got an ACT? Have we got enough people in the dispensary to manage the workload while our backs are turned? Because as this service grows, I think all of us are going to find ourselves pulled into the consultation room more and more for different services. So really look at your teams, look at what they're capable of. If you work for a multiple or you work for a small chain, is go to your team leaders or your managers or your senior teams and say, look, this is what I'm delivering now. This is the growth projection. These are the hours I need to effectively continue with this service and safely and appropriately. Again, with the service, I don't want to go on about the consultations, but a big part of it is observations. If people walk in, if they're poorly. Look, 80% of your consultation is when they walk through. You can tell the way they sit, if they're holding their back, if they look pale, if they look sweaty or clammy. Use your observations. We're good at it. We've been doing consultations over the counter for years now. Now in a room, we sometimes get a bit hesitant and scared, but use what you know. We've all got the skills, and we've got some of the best skills around. Use things like eyes. Why are you here today? Have you any ideas of what it could be? What are your expectations of this consultation? Because sometimes what they expect to happen and what you're thinking is going to happen is going to be totally different. So it's really important to understand why that patient's there and their expectations of you on that, the 15-minute consultation you have. And it's a golden 15 minutes to really make a difference You may supply or you may not supply, but make that consultation count. Use Socrates, understand, is there something else going on? You know, if they're presenting with indigestion or UTI, is there something else going on? Use your instincts. We're really good at that as pharmacists. If someone comes in and says, we all know I've got a pain in the chest, I think it's indigestion, we all automatically will think, hang on a minute, is there something else going on? Trust your instincts. We've all done it for years. Just use your instincts and just follow the process. And it's very, very well laid out for us with the system on pharma outcomes and the training we're still being provided with. Also, people may enter by the minor ailment scheme. So they might come to you and say, I've been referred for a sore throat. You do the examination, they've got fever, they're scoring high on the fever pain score. You see white exudate, you can flick them into the clinical pathway. So you're not stuck in a certain, if it's a minor ailment or a referral, you can move them across into a clinical pathway and say, look, my observations at this moment in time indicative of classic tonsillitis. Yes, you may think, am I right? Am I wrong? But at that moment in time, when you see that patient, your judgment, and as long as you've done the correct process on examination, it may turn out to be something totally different. But at that moment in time, when you're doing that consultation, you have followed the process and you've made a decision to supply. It's better to do so rather than not to if you believe that's a correct thing to do. And if further, if something changes later on and you're worried about that, safety netting is key. So have you told the patient if the symptoms get worse or they seem to deteriorate, or you, for example, against tonsillitis, difficulty swallowing, breathing, please contact A&E, give them information where they can go, or contact the GP. Claim for the work you've done. That's the most important thing I want to say here. We're going to put a lot of effort into seeing these patients, and it's really important we get paid for what we do. But going back to the initial thing, for me, for this, I've been talking to Janice about it with absolute excitement, because it really puts us in a real good light within the community. It takes us away from being, oh, he's the pharmacist that stands behind the glass and gives us our tablets. We're now clinicians. We're going to be counted as clinicians, and there's an opportunity here really to make a big impact on our communities and the NHS as a whole. Because we make a success of this, the list is going to grow, guys, and we'll be able to treat more and more and more. And how many times, I can guarantee there's 10, 15, 20 people in this call said, I've seen an insect bite on someone who's infected and I've had to refer them to the doctor. How frustrating is that? Not anymore, guys. We can actually treat them. And it's absolutely amazing. And have confidence and the passion to get behind the service. And it is a bit of chicken and egg at the moment. Is if I get 10 consultations today, how will I get my 3,000 items out by the end of the week? We've all got that challenge, but we're going to have to go through this rocky period, get our staffing and skill mix right, understand the service, and get our confidence right. For example, looking in the ears, what is otitis media? What am I seeing? The more you do, the more confidence you get. And every time you do a consultation, you'll become stronger, more proficient, and you'll gain confidence. And hopefully the people who have done it are really enjoying the service, because I truly am, because the satisfaction of able to treat an UTI or a child with otitis media is, for me, like I said in the beginning of my slide, is the biggest game changer we've ever had. And I think all of us should together be ambassadors for this service and just take it to the next level and prove to the NHS and prove that Greater Manchester can actually stand out from the crowd and really, really make a difference to the communities. And that's a summary from me so far. But if you've got any questions, I think later on Alison will be opening some questions up how the service has been. Please ask away, because I truly am really passionate around this service, and I'm not just saying that, I really do enjoy it, and I hope you guys do too. That's enough for me.
Thanks, Samuel. It's really passionate presentation around the things that you've been doing, and I think there'll be lots of questions later on around practical things. I just want to say a big thank you actually to everybody, not only for being on the call this evening, but particularly for such fabulous figures that have come through for Greater Manchester, already achieved so much, and that will have been contributed to by all of you that are already here on the call and your colleagues around Greater Manchester. I think we should feel very proud of what we've actually achieved so far. I want to just build on a couple of things that Amal has said and reiterate that this is our biggest opportunity to take our roles as community pharmacists to the next level. And can you move on to the next slide, Alison, please? It does require us all to think a little bit differently. And the link into professional standards is around that person-centred care and that making patients your first concern. And like all new services, I just wanted to remind you that there is a requirement to make sure that, as well as delivering all the NHS contractual requirements linked to this, that we do need to have risk assessments in place, and we do need to make sure that we are meeting GPHC standards. However, there's no right or wrong way to do this. This is about showing that you've considered the challenges that might arise and what you're going to do about them if that happens, and what your mitigation is. And there's a lot of mitigation already actually in the farm outcomes system and already in the protocols, but it's about us thinking as professionals, not just about the what. And because this is a new service, we are actually quite into the process and looking at all the charts, and there's so much information to try and help you, and it can be a bit daunting. But the professional standards part is about the how and the experience of the patient. And in the same way as Amal's just talked about how passionately he feels about the service and how motivated he feels when he's actually delivering it, it's actually really great for patients. This is a far better experience for them to actually be seen by a pharmacist in a pharmacy close to home, rather than waiting for weeks and weeks to see the doctor. So it is that wider experience, but it does require us to build some new habits. And the best way to deliver the service in the most professional way is to think about how you would feel if you were the patient, to step into their shoes. Think about what they're thinking, or think about what you would want to happen if this was one of your family that was being seen. So we've already got all the skills. I think there's a lot about having confidence in ourselves. Do you want to go on to the next slide, please, Alison? And I heard a lot on the training sessions about attendees saying, that they were worried about being confident and wanting to feel confident, and just wanted to pick up on confidence, because confidence itself isn't actually a thing in its own right. Confidence comes from a number of different factors, and they're the factors on the screen. So you tend to feel confident if actually you've done your training, you've developed some skills, and if you're putting all those things, communication and asking those insightful questions into place, which comes through following the protocols. And all pharmacists have that intuition and that sixth sense. We just seem to know when something's not quite right. So trust that sixth sense, use that feeling, and use your skills to actually explore what's happening with the patient. It's that asking the questions that actually helps you feel confident in what you're doing. And there is no shame in referring somebody. If you're not sure or you think it's something different, then refer them on, or safety net, or signpost to wherever you think is most appropriate. We don't have to deal with every single thing. We have to deal with what we're able to do in a consistent, caring and competent way. And the more we do, the more confident everybody will feel, because you get to experience all the different pathways and all the different aspects of what can be actually given to patients. Next slide, please, Alison. So I just wanted to think and spend a few minutes just thinking actually about some of the things that have been raised by our GP colleagues in terms of some queries that have come through. And patient service and centred care, a key element of that is safe and effective handover. And one of the ways that we can do that is to focus on the standard of our record keeping, and also the way that we actually hand over information to other healthcare professionals. Now, many of you will have covered this in either the training modules that you've been attending over the last month or so, or on other previous training. But SABA is a simple, easy and effective way to really pass on information, make sure nothing's missed, but to do it in a way that's easier for the recipient of the information. There are other acronyms, but SABA is just a really basic, simple one that means you can just think through it in an easy way. So if you structure your thinking around that when you're passing the information on, then it means that the next person in the chain, if that's needed, will be able to act promptly and efficiently and effectively, but will also save the patient having to keep going over the same thing again and again, which we all know from patient feedback can be really frustrating. But think about what you'd want to know. If you were having somebody pass to you and you're the professional who's receiving this person, what you want to know, and think about that information. So it's about being concise and it's about using professional language. Remember, this is going into the record, and what's in the record stays in the record. So you want it to be something that you're not embarrassed about anybody seeing, and that it actually makes sense to the person reading it. The most simple, effective language is just to say it straight away. Don't use anything fancy, but make sure it's clear and actually says what you mean it is to be. So it could be verbal. We can do verbal handover, but most of the time that we're handing people over, it will be actually through the record and written. So just before you press send and put it into the system, just read through it to make sure it makes sense and say, is this an accurate reflection of what I've had to do with this patient, and will this help the next colleague in the chain do what's needed? So I've got some examples for you on the next slide of some record keeping. So remember, everything you enter into farm outcomes will be visible to the practice. And that's why it's important that you think about what you're writing there and only put things that are appropriate. But you can see there the difference. I'm not going to read them to you, you can read them on the slide yourself, but the difference between an example of some good notes that gives some information that would be helpful if you were the clinician who was receiving that information, but also to the next person in the chain. But if you look particularly at the examples of the poor notes, you have to ask yourself, what can somebody do with that? What does patient complaining of multiple issues mean? Yes, that's probably a true statement of fact. They did have multiple issues, but what are they? What does it mean? What do we want the next person to do about that? So think about how you can expand on that so that it's actually useful information, because it's not helpful to just put something so short and blunt. It's not incorrect, as in it's factually correct that is what happened, but it's about giving that colour to it so that actually there's a bit of a story behind it. And you can see the ones that are examples of the good notes. It's a bit of a story. It's telling you what happened. It's telling you what was said, or it's telling you what was implied by a parent, or what was seen. So it's taking all those things together and giving a bit of a summary so that actually somebody knows what you thought, what you tried, what you didn't try, what you did, or what you didn't do. And it does take time. And again, this is another area that comes with practice, but it's also good professional practice to sometimes look back at the notes that you've made and actually reflect on that and think, actually, next time, could I put something more in there? So it's a way of actually improving your practice and a great way of escalating to a GP. And there's no harm in doing what Amal's done, which is when you've got that relationship with your surgery, going and having a chat with them, ask them for some feedback on your notes. Is the notes, and are the notes that you are making actually helping them? Have that conversation. Ask them to suggest improvements, because that's how we all get better at what we do. We're all learning, we're all on this steep learning curve together, but only by getting some feedback do we actually learn and develop, and then we can be actually tailoring the messages to the people who want us to act on them. So the next slide, please. This will only mean something to you if I've actually watched Ted Lasso. If you haven't watched Ted Lasso, I highly recommend it. But I think the biggest challenge in community pharmacy at the moment is that we have to have belief in ourselves and in our teams. We have all these skills, we have this knowledge. It's about putting it into practice, and as a profession we're not very good at celebrating what we've achieved. And I keep saying to everybody that any patient that you help is an appointment that's saved. So we should be thinking about what we have done rather than perhaps what we haven't done, and over the next few months the numbers will start to grow, so that the plan being that by the time we get to next winter we will be the first port of call for patients with any of these conditions, and those relationships with the surgery will be, it's just automatic, passing people through to us in this way. So build that trust, build those relationships with the surgery, and help the patients help themselves by giving them this information. And I'm really proud of everything that's been achieved so far in Greater Manchester, and we'll be moving forward to even more success over the coming months as things settle down. So I'm passing over to Lou now, who's going to talk about some of the tools that we've got to help support you. So thanks, Lou.
Thanks, Janice. I'm Louise Gatley. I'm the Director of Services at Greater Manchester LPC, Community Pharmacy Greater Manchester. I'm going to go through some of the supporting resources because we know there's a huge amount of information out there for you, and it's sometimes working out which bits to look at and when. But before I do that, I want to highlight some more of the fabulous work that you're all doing. You know, we've already had some really great stories from Amal, but I think it's really important that we share the success. So I've just got a couple of things here that I just want to highlight to you. And both these cases came from the same pharmacy, just a contractor in the Northwest, and they both involved women in their 50s, and they were both about the hypertension case finding service. So moving a little bit away from pharmacy first, but again, another kind of evidence of success of community pharmacy. So on both occasions, a pharmacist decided to do a blood pressure check on these patients because they were describing some symptoms that he was concerned about when they walked in, just for routine advice from the pharmacist. The first one had a BP reading that was normal, but the pulse rate was 180, so it was a fairly simple referral straight through to A&E. And that patient's now come back to him and said thank you, and they're undergoing some further investigation. But the second one was a bit more unusual. This was a patient who had a high BP reading, so he arranged for the patient to come back the next day for an ABPM. And when she came back, she was very breathless, and he was really worried about her. And he had a pulse oximeter that he decided to use, and she had a SATs of 89%. And she was sent straight to A&E, another one, and it was the same week. Same pharmacist, and her husband called in a couple of days later to say she'd been diagnosed with bilateral lung clots, and the A&E had told him that the pharmacist had saved her life. And that's quite a powerful message to get back, isn't it? It was something that he was really proud of, and a story that he wanted to share with us. And these are really good examples of the kind of interventions we make on a daily basis. It's really important that we acknowledge them and that we share them. I'm sure that everybody on this call has got their own stories to tell, and we really want to hear those stories. We want to share them. We want to work with you. So if you've got time, please do get in touch with us at CPGen, just to give us a summary of what's happening in your pharmacies. Karishma's on the webinar tonight. She's our comms officer, and she'd really like to speak to you. So if you've got anything you want to talk about, pop your name in the chat now, or get in touch later, and we're really pleased for you to do that. Next slide, please, Alison. Thank you. So just moving on to the resources now, and this will be quite quick because I think you're probably aware of most of these already, but just to give me a little bit of a summary because there is so much. So the first one there is the resources and things we've done at CPGen. Lovejeet's already talked about those, so I won't dwell on it. But we have done quite a few briefings, and we do have a new briefing coming shortly around remote consultation, so please do look out for that. And as well as that, we've been working with the GM Healthcare Academy to make virtual outcomes available to all of you. This is something that I really recommend you have a look at. It's a great free learning resource. It's for the whole pharmacy team. Their pharmacy first training includes an overview module for the service, and they've delivered a series of short videos as well on each of the 7 clinical pathways. At the end, you can answer a few questions if you want to get a certificate, which I know a lot of pharmacy team members really like to get, just to demonstrate their CPD. But really good resource. It's free. If we don't use it, we won't have it. So please do have a look. We have noticed a big uptake in usage recently, but I'm sure there's some of you that have not seen it yet. So please do have a look. Really easy to log into that using your ODS code. Moving on then to Community Pharmacy England, their webpage has got a huge amount of resource on it, but I suppose now the service is live. Looking at the key bits I'd look at would be the GP briefings, the letters to use with your local practices, the promotional materials, all the things that Amal talked about earlier. These tools will help you with those conversations and that message to patients. There's also, the usual stuff, the staff briefings and webinars, clinical pathway videos that they developed some time ago. If you need to refresh your knowledge, they're all there on that website too. CPPE have their gateway page, and they're continuing to develop that. There's tons of resources on there, lots of training. So if you've not already had a look at that, have a look. And they've got a great self-assessment tool there that might help you identify any knowledge gaps that you've got. And finally, other online resources we've got for online training, people like Planning Skills and Agilio, where we've had some great feedback from some of our contractors on those. And then people like NPA, Newmark Avicenna, if you're members, they've got tools to help as well with patient comms and resources. And finally, Farm Outcomes, they're developing more user guides. They've got the videos, so please do have a look at those if there's anything that you're not too sure about. And from there, I will pass over to Lovejoy, who will just do the final summary for us. Thank you.
Thank you so much, Lou. That was very comprehensive. Next slide, please. So thank you so much, everybody, for attending. I want to just take this opportunity to thank all the speakers and thank actually everybody who's been on the team on this webinar, because it's been a lot of hard work to prepare for the delivery and implementation of this service. But in a summary, we've got Lou, who's covered the resources for community pharmacy. Amal's done a fantastic and very inspiring presentation on the need for the workforce and skill mix and how to deliver the service in your pharmacy. And I would just want to emphasize the important point you made about engagement and building relationships with general practice. Having spoken to maybe 10 pharmacists in the last couple of days, it's exactly what Amal said. And that list, the green-red list, and the list of conditions and the ages is an absolutely critical tool that you can use to engage with your general practice teams. And I will share that in the chat because we've created a hub page in the Primary Care Board website to make it easier. Janice has done a fantastic overview of professional standards, thank you. And Ali's done a fantastic overview of the data. And of course, Alison, who's provided a fantastic summary of the service itself. So at this point, I'm just going to hand over back to Alison for share the Q&A session. Thank you. You're on mute, hun, sorry.
Apologies, thank you. I stopped sharing my screen. We've had a couple of questions that have come through in the chat box, and I think we've got some in the Q&A as well. So I'll dip between the two, and hopefully we can get all of these questions addressed. The first question that I've picked up is around distance selling pharmacies, some issues around kind of exclusion of DSPs in Pharmacy First, some issues with 111 online referrals to DSPs. So I'm wondering, Lovejoy, if maybe you could pick that one up, please.
Sorry, I kind of lost sound there for a second. My apologies.
That's okay, no. There's a question in the chat from Haroon, who's talking about Pharmacy First not being a level playing field for distance selling pharmacies. So Haroon's raised some concerns around the disparity in the launch and exclusion of DSPs, particularly with the 111 online referrals.
And we completely appreciate the perspective and the views of DSPs. I think all I can say at this stage is that the issue is recognised. It has been fed back. Community Pharmacy England are fully aware of this issue, and that issue is being resolved nationally. I think we've done everything that we can here as a team and make sure that your views and the impact on you has been flagged back. But we agree that at this moment in time, it's not a level playing field and it absolutely needs to be corrected. Unfortunately, at this stage, we don't have a timeline for when this issue will be resolved, but I do understand that there is progression ongoing to resolve this issue for you all.
Thanks, Lovejoy. Next question in the chat came around tonsillitis. Does tonsillitis come under acute sore throat? Lou, I know you've put in a link to the CKS clinical knowledge summaries of NICE. I wondered if you wanted to just pick up on that question.
Yeah, I've had a quick look at the NICE CKS just to confirm, but NICE CKS class is acute sore throat, so acute pharyngitis or tonsillitis. So yeah, it does. Yeah.
Brilliant, thank you. Let's have a look in the Q&A, see what we've got in there. Oh, I think we've got some duplication there, so I'll stick to the chat. What other questions have we got? There's a question around Otigo being out of stock. What's the next step for otitis media? I know we did receive some guidance on this from the Northwest around what to do about out of stock medicines. So I think we're just looking in the background to pull that guidance out, and then we can make sure that everybody's shared that. I don't know if you've managed to find it, Lou.
I've shared it. I've put it onto the chat. I've responded to the question.
Fantastic.
So, do you want me to go through there's 3 bullet points I think that were part of a primary care comms that went out last week. It was around impetigo treatment rather than O2go, but I think it's relevant to this. So it says where clinically appropriate and the medicine can be obtained in a timely manner, order it. If it's likely that stock will be available from another pharmacy, refer them on to the other pharmacy. But if the product is generally unavailable, the patient should be referred to another healthcare provider, which could be their GP, for assessment and prescription of an alternative product as appropriate. And what they're saying is not to go for the second line treatments, because that could be the use of an inappropriate antibiotic for that patient. So they are being quite clear that you don't just defer to the second line drug, and those are to be used under the pathway instructions for each of the clinical pathways.
Can I just add
in there? But if you're
Sorry, can I just add, Lou, that I was in a meeting with the Integration Fund leads who were looking at some of the extensions to Pharmacy First, and they're trying to see if there are any other products that they could get agreed that could be substitutes. So that work's going on behind the scenes between NHS England and CPE. So it might well be that we get some other things that come through that we can use. And of course, we shouldn't forget that we can still use the self-care type recommendations of things that we would do. We shouldn't forget some of the basics that we can actually give to patients to help with that. So as soon as we hear if there's any other products, we'll obviously communicate that straight to you.
Thanks, Janice and Lou. Next question from Jonathan. Is there any work being done to integrate minor ailments recording system with Pharmacy First? It's very clunky and there's lots of duplication. I'm going to give that one to you, Lovejoy, because I know minor ailment service is one of your favourite topics.
Thank you very much. Yeah. And just on the previous question, just to say that all these issues are also raised by the chief officers as well to Community Pharmacy England, and there's been a discussion as well raising the medicine shortages and the impact. So I think it's being tackled from many angles. It's a really good question, actually, Jonathan, and I acknowledge and recognise the fact that the minor ailments recording or the pharma outcomes module is quite onerous. And I think we've had that feedback, haven't we, Lou and Adrian, particularly I'm looking at, in terms of how onerous. At this moment in time, the Pharmacy First is a national service, and therefore we can't really integrate, if you like, the pharma outcomes modules together, because it's an additional GM NHS locally commissioned service, so it will have to be kept separate. However, post the winter surge plans, which the winter surge, that you're delivering now, we will be reviewing the commissioning arrangements. And as part of that process, one of the recommendations that we'll submit to the ICB is to ensure that we review the pharma outcomes module to make it less onerous with a lower administrative burden, because it has come back as quite a strongly forced point, really, from contractors over and over again, that the length of time it takes to complete that module is actually deterring them from engaging in the service. I don't think that we'll be able to integrate that locally commissioned service with the national pharma outcomes module, but we will certainly do our best to try and simplify it once the opportunity arises. Thank you.
Thanks, Lovejoy.
I think, can I add one thing there as well? We have got the survey that we've sent out to US contractors to get your feedback on the MAS service. So if you've not already filled that in, please do so. Adrian is collating that data for us and summarising it all so we can take it back to help inform our negotiations. So please do fill that survey in. It's really important. Thank you.
Thanks, guys. Does anybody else have any other questions for us? Please do feel free to come off mute and talk to us if you'd like to. Or if you'd rather post your questions in the chat or the Q&A, then please do feel free. I can't see any other questions at this time. Has anybody else on the presenting team got anything they wanted to flag or highlight?
I thought I saw somebody's hand go up, but then it's vanished. So I don't know whether that question was answered or whether they changed their mind.
Oh, I missed that. Sorry, Janice.
Yeah, it was before when people were talking.
It just flashed, didn't it, for a second? I didn't see who it was. I only have one point to make, and that is that there's a number of opportunities to really use the opportunity of Pharmacy First, hypertension case finding and contraception to really support integrated working with general practice. I understand it's very challenging, and I think you're all doing a fantastic job at the moment. But I think we do, as Amal said, need to take it a step further. So I have put a link in the chat which is a link that you can share with general practice that only has the most important resources for general practice on there, including the green red list and a list of the conditions and the ages, because that seems to be a similar theme that's coming back from many contractors, that they don't feel like they're getting the right referrals. But I think the opportunity is there for you to speak directly to your general practice and share those resources. Of course, myself, Alison, Lou and the team are all also engaging with general practice and PCNs to make sure that they understand that. But I think it will be most impactful if you're the ones communicating regularly, so that you can resolve issues and them not being escalated to us and they're resolved locally. I don't know if Amal's just come off mute, so do you want to come in, Amal?
Yeah, I just want to build on what Louise and Lovejoy said around the service. Is we're in a really unique place. Is we see our patients week in, week out, and we see changes in them. We, you know, all of us seen a patient that's suddenly getting confused, or for example, Louise gave an example of the blood clot example. We see these people day in, day out. We can see a change in their behaviour or their illness. So we're just going to build. We just build on what we already know, and trust your intuition. Honestly, trust your intuition. And the examples that Louise gave was just intuition. We know our patients better than any of us. And some of us have been around in branches for 10 years, 15 years, 4 years. But you see Mrs. Jones every month for the past 2 years. And they present with you, and your instincts are 100% right. Why is she suddenly complaining of earache or stomach ache or whatever it is? And like Janice says, be inquisitive, be curious, and think about what possibly could be the differential diagnosis with this patient. And we can really, really take this service and, you know, challenge yourselves. That's what I say, challenge yourselves. And I try to do that. Is what else could it be? Or how could I approach this a bit differently? Or review your consultation. How could I have done that a bit better? You know, what could I have done differently? Could I have explained it differently? Or could I have approached it from a different angle? Because we're all going to get some good consultations, some mediocre ones, and some bad consultations. And all this is great because we're just going to learn and get better. So all I say is embrace. We know our people. We know our patients. And just be confident enough in yourselves. Just approach these patients and just embrace the service. And that's all I've got to say. And thanks for everyone on the call.
Thanks, Amal. Really, really great. Thank you very much for your contribution. Does anybody have any other questions?
Is there a link missing on that? It says resources for general practice. You can share this link with GPs. I can't see the link on my in the chat on
sorry,
my bit.
I started answering the question, so I will put it in there.
All right. I didn't want. I thought people might want to copy it. So
yeah, no problem. I will share that now.
Have you got another question, Amal, or is that your hand from before?
Legacy hand. There's one in every Teams call. Anybody else got any other questions for us? And there's the link from Lovejoy. Thank you very much, Lovejoy.
Yes, if anybody does it, I just didn't press the send button. That's why. Thank you, Jenny.
If anybody does have any questions that they don't feel they want to share in the call, then you can contact the LPC directly using the enquiries email address. I don't know if Adrian or Karishma could just pop that in the chat, and then people have got that if they need it, if they do have any other questions. But if we've got no further questions, then we will leave the call there for this evening. We will make the recording available afterwards, and we will also share the slides and make those available to you too. So thanks very much for giving up your evening to join the webinar this evening. Hopefully you found it useful, and best of luck with continuing to provide a really great quality service for your patients for Pharmacy First. Thank you.